Greetings, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer. This episode, as all our episodes, is produced by Bright Spots Ventures. Now, our mission is to spotlight what is working in healthcare and help scale it. We bring leaders together each and every episode from health plans, health providers, and innovative solution organizations to share the strategies that create real-world impact. Now, a few years ago, across the pond in Finland, transit planners in Helsinki found something really odd in their data. In neighborhoods with some of the best bus routes, older adults were barely riding. Now, the early theories that you're probably guessing made sense. Maybe there was mobility issues. Maybe it was convenience. Maybe people simply preferred other modes of transportation. But when researchers actually sat down with these older residents, they heard something very different. People actually wanted to take the bus. However, they didn't feel confident using the system. They were worried about getting on the wrong route. They found the signage super confusing. They weren't sure the driver would wait long enough to allow them to board. So none of it felt designed with the elderly in mind. So what happened? The city redesigned the entire experience. Clearer signs, better lighting, sheltered seating while they waited, real-time arrival displays when the bus was going to get there, and then drivers were trained to be more patient, and they actually started putting in the buses those low floors that made boarding feel safe instead of super stressful. So what happened? Ridership increased, and what was really happening was there was a shift overall with confidence. People finally believed the system had been built for them, and that changed everything, right? And that Helsinki moment is exactly where Medicaid plans are today. We're heading into another wave of redetermination. We are preparing for federal work requirements, and millions of members who are already feeling vulnerable, they're being asked to navigate systems that do not always feel clear, safe, or designed for them, for their lives. So when confidence is low and the stakes are high, even small uncertainties are going to stop someone from actually taking action. That is at the heart of today's episode and the conversation we have planned for you. How Medicaid plans can reduce friction, rebuild that trust, and help members stay covered and stay healthy. Before we dive in, I want to acknowledge GroundGame.Health for supporting today's episode. GroundGame is a human impact company, and they help Medicaid members stay covered and get care by removing real-world barriers that stand in their way. They do this through human connection. So community-based engagement, meeting members where they are, and creating a culturally tailored experience. Let me repeat that so it's so important. A culturally tailored experience at the level of the individual. They have a right touch model that blends personalized outreach with deep relationships across community organizations to close those gaps in care, surface hidden needs, and actually solve them. So in the Helsinki, it's basically the Helsinki story in action. When you redesign experience around the person, everything changes. So you could check them out at GroundGame.Health. Really excited to have them part of the Bright Spots family. All right, let's take this Helsinki insight and move it forward as members are facing this moment of uncertainty, and all of you health plans are facing a moment of consequence. There's this now next wave here that will be shaped and how clearly, confidently, and compassionately all of the health plans listening today guide their members through this next chapter. So today, we're joined by an incredible group of guests. You see in front of you Terrie Hottle. She's the Director of Product Implementation and Deployment at CareSource. You have Molly Whittle, Vice President of Medicaid Fiscal Strategy at WellSense Health Plan. And in a moment, you're going to meet Abner Mason. He's the Chief Strategy and Transformation Officer at GroundGame.Health. If you want to check out who these folks are, we never take the time to read their bios in full, but if you're listening to the podcast, we put it into the podcast description notes on your phone or your tablet. And if you're watching live in our studio audience, we put it into the chat in the Zoom interface here today. All right. So let's dive in. Oh, by the way, today's episode will be available on YouTube as soon as we're done, as well as anywhere you consume podcasts, and that drops on Tuesday. So you'll have an audio version available to you on Tuesday, video version on YouTube available just about at 1 o'clock East Coast time. You could go to YouTube, type in Bright Spots in Healthcare, or if it's easier for you, go to brightspotsinhealthcare.com, and there's direct links to any of the podcast apps and our YouTube channel. You should subscribe too, then it automatically gets downloaded into your device. All right, let's get started. Terrie, I want to start with you, and you're at CareSource. Let's go back to Dayton, Ohio, and why did CareSource start investing in workforce development? And can you provide maybe a high-level overview of how the program works? So let's say not too deep, because we'll go deeper later on in the episode.
Sure, absolutely. Before I talk about that, I just want to talk about CareSource is an MCO. It's a nonprofit managed care company, and our headquartered in Dayton, Ohio, but we're now in about 14 different states. I just wanted to sort of capitalize on that nonprofit status of our MCO. So yeah, back in 2008 in Dayton, Ohio's big employer, GM, General Motors, they closed shop and left Dayton. And of course, in 2008, we all know what was happening then in the economy. And it just left a devastating economic hardship in the Dayton area, which is where CareSource is headquartered. And that economic hardship sort of, it just continued. So in around 2014, we started to turn to our members and ask them. We started, having focus groups and surveys. Think Tank came in. They're a Dayton-based company. They came in and did some focus groups. And we really basically asked our members, what are you not getting from your insurance, from your Medicaid managed care company that you want help with? And the answers were a little surprising. So by far, the answer was employment. And we thought, wow, okay, so that's unique. No one's doing that. No one's providing workforce development for their Medicaid membership. And so we embarked on creating life services. And under life services, CareSource Job Connect. And so then what happened was a company came in and bought that old General Motors building. And they needed, they're a glass manufacturing company, and they needed employees now. And we grabbed hold of them and partnered with them among 3 or 4 other pretty well-known companies in Dayton. And we said, hey, we've got this workforce development program that we're implementing with life coaches. And we would like to offer you a ready pool of candidates that are job ready, that have been working with life coaches, that have got their SDOH or social determinants of health barriers down. And we would like to offer you a pool of candidates instead of you going and hiring a staffing agency, which most large companies do that need employment or employees pretty quickly. And so that really began what is now currently, and we'll talk later about this program that is now replicated in 5 states. And so that's where it started, and that's why it started, as we reached out to them, what do you need? And we met that need.
Wow. So you not only forget about the healthcare part of this for a moment, you were taking folks in the community, you were taking a new employer in the community, you were matching the two, win-win for both the business and for the local folks and for the overall economy. There's a trickle there. And not to mention the overall health of Medicaid workers, which of course, hopefully in the long run benefits CareSource as well. So it's sort of a
100%.
Win-win, win-win.
Absolutely. That's how we see it.
Yeah, I love it. You guys do a lot of innovative things over there. We will, I want to come back to you in a little bit. We'll dive into that. Sure. Terrie's story, it reminds me of when you listen to members and they tell you what they need. And then, so Molly, I'm bringing Molly Whittle. She's the VP of Medicaid Fiscal Strategy at WellSense Health Plan. Molly, you sit at this intersection of finance and strategy for Cade in both my home state of Massachusetts and New Hampshire, lived there free. So when you look back at the public health emergency and the first redetermination cycle, what actually changed in your Medicaid population around, and your cost? And then how has that experience, this is the most important part, how has that experience reshaped how you're thinking about the next few years, thinking about sort of 2026, 27, 28?
It has shaped it quite a bit. So for just some general context, WellSense Health Plan is part of Boston Medical Center. So we have a pretty large presence in the Massachusetts area. We oversee about 500,000 Medicaid members in Massachusetts. Medicaid in Massachusetts is largely provided through ACO structures, about accountable care organizations. So we partner directly with other providers who are also at risk for their Medicaid population. We also have Medicaid product line in New Hampshire, which is more of a traditional MCO type of product. In terms of, what we learned from the public health emergency and the first really large round of redeterminations that we went through is that the population post-redetermination in Medicaid looked very different than the population we were serving during the public health emergency. Most notably, the population post-public health emergency during COVID was much higher acuity. So on average, our medical PMPM costs were about anywhere from 10 to over 20% higher for the population that we saw post redetermination versus the population we saw pre-redetermination. If you think about kind of the changes that we know are going to be coming under OB3 with work requirements are really going to impact able-bodied adults, right? Able-bodied adults are the least costly to insure in general, right? So I do anticipate that some of the acuity changes we saw in our population that happened during the public health emergency will continue to see that again once work requirements are implemented. So we are doing a lot of work right now to engage with our states to make sure that when they are setting managed care rates, that they are being aware of what the population acuity is going to look like for that experience period. What happened in the public health emergency is rates were not set appropriately. And that is because the base period that our states were using for rate development reflected a population that in general just looked a lot healthier than the population post redetermination, right? So it's critical that health plans that have a large Medicaid footprint are engaging with the states to make sure that they are having realistic expectations of what is medical trend going to look like for the Medicaid population post redeterminations. But also on the back end that there are stopgap mechanisms if the state actuaries are incorrect in their rate setting assumptions. Ultimately, at the end of the day, we don't want health plans or providers being at risk because of the fact that the population looks different than what state actuaries had assumed.
Got it. And so Molly, don't shoot me here because I'm going to go off script just for a second. And if you don't know the answer, you have every right to say, I don't know. So just I want to give you that out. It strikes me, and I know Medicaid not intentionally is sometimes a little bit behind their care and commercial family members when it comes to adoption of new technologies. I'm curious, as you talk about this and some of the uncertainty in the population makeup, if different predictive AI solutions are being explored to more accurately forecast, how your population is changing in real time, or if it's not in real time, closer to real time than we've ever been able to do now that we have now that we have artificial intelligence combined with big data and everything that's sort of converging on us here in 26.
Yeah, I think it's actually two areas where technology will play a critical role when we talk about work requirements in the Medicaid population. I think the first area is doing eligibility checks. So that is actually, I would say, more so on the state agency side of making sure that they are working with partners that really simplify the process, and make it as seamless as possible for individuals to be able to prove that they are meeting the work requirements so that they can retain coverage, right? So I think that is a very critical area where we should be leveraging technology more, and even areas where we can integrate technology. So if we already have information that a individual is meeting the work requirements, that's getting fed to the state agencies, right? So I think that is one critical area for technology. I think another critical area for technology that we're thinking about at WellSense is how can we better leverage AI within our own claims data so we can better understand how medical costs are trending and therefore what interventions we need to start thinking about on our clinical care management side, right? So that is going to be even more important as our population starts to shift and starts to look a little bit different than perhaps the population we're covering right now.
Makes sense. It makes total sense, actually. I'm going to, you actually opened it up. So I'm going to do a quick little PSA for everyone. So those of you who are unfamiliar with us, you're attending your first episode, Bright Spots Ventures, we like providing a platform for peers to meet each other, share ideas, build relationships, build trust. We believe that is fundamentally the foundation to how we're going to accelerate improvement in healthcare for all of us in our lifetime. And we have two exciting events coming up in the next week and a half. It's like a week. But they're private events. So there's some people here not going to be eligible. So I apologize in advance. These are for health plan leaders only. And Molly mentioned one of them. So I want to make sure I bring it up. The second is on Wednesday, December 17th. This is where I was going with. At 12 o'clock, we're having a health plan only event. It's called the AI Roadmap for Member Engagement from Pilots to Scaled Impact. And it's really well attended right now. We may have to have 2 breakout rooms. It's private. I facilitate and host it, and it's all about sharing ideas. It's 1 hour from 12 to 1. The second one we're doing, really, it's the first one, is tomorrow. I know, a little late notice for everyone. It's around beyond adherence, and it's talking about the personalization in the medication experience to drive stars. I know Medicare, not Medicaid, retention and total cost performance. So if you are at a health plan and want to attend either of those or both, we'll put up a poll right now. That event for tomorrow is at 11 a.m., which is a little early for you on the West Coast, but coffee with Eric is a lot of fun and a lot of your peers. So, and if you're at a solution provider or another organization, you feel left out, we're happy to talk to you separately about how we can organize some of these things with you in partnership with you. So, Molly, you teamed me up, so I just wanted to bring that up right now. All right, let's poor Abner. So Abner Mason has been waiting. He's the Chief Strategy Officer and Transformation Officer at GroundGame.Health. And we were having some technical issues getting him on into our virtual sort of room here, but we have him on audio only, I believe. So Abner, can you hear me?
I can hear you. Can you hear me?
Yeah, perfect. Just, yeah.
Okay, great.
You're totally audible. Just make sure you speak up almost at like you're at a soccer game and you're a little bit excited, right? So when you look,
all right,
when you look across your work with different health plans, where have you seen that personalized outreach move the needle most? And maybe what did that approach look like in practice? If there was an example of a health plan you've seen to sort of just do it a little bit differently.
Sure. And let me know if you have any trouble hearing me. And apologies again for the technical glitch. We're still trying to solve it. But I think the best way to answer that is to give an example. And so we worked with a regional health plan in the Northeast. And this plan was struggling with HEDIS quality measures, a Medicaid plan. And they, in particular with women, they had tried lots of ways to engage with women, and there were certain women and mothers. So the goal was a number of measures, but also focused on women, well-child visits, cervical cancer screenings, and in this case, also some diabetes measures they were really struggling with. And so we partnered with the plan and worked with them, and what they, as they described what the challenge they were facing, it was pretty clear that one of the problems was just it was hard to get the attention of these women. They were busy, they were moms, they were low income, they're struggling, they're multicultural, low health literacy, and so one of the things that we have learned in our work is that if you personalize the engagement, if you treat people like who they are matters, you can get better results. You can begin a path to earning trust with the member. And too often in healthcare, we've taken an approach of sort of one size fits all. And there are reasons for that that are historical, but frankly, the society has changed and people don't want to be treated like they're a number. They want personalized engagement. Other parts of our economy do that. Take Netflix or Amazon. They quickly figure out who you are, what you like, and they start to treat you like they know who you are. And so we said, let's try that. And we had done a lot of research. We've been doing this for a while, and we were able to test the messaging with white moms, with Latino moms, and with African American moms. And what we found was that if we could tailor the messaging so that with white moms we emphasized getting in and out of the clinic quickly, that we could do it, that we could help them book the appointment and book it at a time that was convenient and get them in and out quickly. We tested that and we got a much higher response. With Latino moms, that message didn't work very well, but we were able to use different messaging, which talked about the importance of motherhood, both before the baby's born and after the baby's born, and that you want to be there for that child's life. And that motherhood messaging, and we toyed with different approaches, really got great traction with Latino moms. And with African American moms, interestingly, we tried a couple things, and ultimately, what worked really well was helping those moms to see that that we could help them to find a trusted physician. A lot of those moms just didn't have a great trusted relationship with the healthcare system, and by helping them to pick a physician, first acknowledging that what they were feeling was legitimate. That's the first thing. We acknowledged that concern was legitimate. Yep. And then we said, we can help you find a trusted doctor. We got incredible results. We got a 40% reduction in well-child visit gaps for this plan. 2,500 women received cervical cancer screenings, and we got a 21% decrease in the diabetes measure in terms of gap closure. So this personalization really does work. It's effective.
Wow. Okay. So hold on. I got to repeat this back. And I know my team I'm taking notes while we're going here. And so my team, if we could maybe, let's paste some of this into the chat for those who are here live. So let me just repeat that in case people missed that. So you took focusing on women's health and expectant moms specifically, you identified different sort of fundamental need or objectives of the different ethnicities. So white, Latinx, or Latino moms and African American moms. And as you differentiated those, you nuanced your messaging and you saw this massive lift. Could you just repeat those? I think I lost the results. Could you repeat the results again?
Sure. So for well-child visits, we were able to close 40% of the gaps. There was a significant number of gaps for well-child visits, so 40% reduction in gaps. For cervical cancer screenings, we counted, it was the number, an additional 2,500 women who the plan had not been able to come in to get screened for cervical cancer. They were able to get them in. And for the diabetes measure, it was a 21% reduction in gaps. So really a big uplift. And it sort of proved the point here that I think, we're talking about, Eric, here, is that and I want to emphasize this, if you take the time to understand a little, not a lot, you don't need to know a little about who that member is, and then tailor the messaging, you will build trust and get better results.
Great stuff. All right. Love that. 40% gap closure, 2,500 increase in cervical cancer screening, 21% reduction in gap for diabetes measured. I scribbled it. I got it, I think. Great stuff. Thanks, Abner. Terrie, I'm going to turn back into sort of, I want to continue focusing on programs that are working and come back to you and your Job Connect program. Can you take us through like the core elements and maybe walk us through the things that you built into the model that make it different from maybe a traditional workforce program and help members actually reach sustainable employment versus just being sort of eye candy?
Right. Absolutely. Yeah, sure. And I just want to say I could not agree with Abner more when we talk about personalized approach. And I said, I think that is exactly why our program works so well, because it's a one-on-one, right? It's pretty intensive with a life coach. So I'll start from who's all eligible. And this is a big differentiator and a big lift for an MCO to do. So you have to be a CareSource member, right? Or here's where it's different. Or you can be a parent or guardian of a CareSource member. So our plan actually works with non-members. And so that mom or that dad that maybe has a different plan, maybe has ACA, maybe has somewhere else, as long as their child has CareSource, they're eligible for the program. We did that specifically because we believe that if you help a member, if you help a parent or guardian or a family member, it helps the health of the whole family. If their income can increase and their SPOH barriers can decrease. So that's the first thing. And our referrals come from community-based partnerships. They come from providers. They come from our internal care management team. And then they come from self-referrals. So our members know about the program via member newsletters and billboards and radio ads, right? So once they enroll, they get a life coach. And what we did recently in the last couple of years, we separated out for those members that are coming in that say, I just really need help with housing, or, I'm housing unstable and I just need help with housing. I'm not ready for employment yet. Well, they go in sort of a different program, but they still get the life coach, and that life coach works with them to meet their goals, meet them where they're at, and then work on the goals, the SPOH goals. Then we have those members that come in and says, I need employment, or I need better employment. I'd like to help with education. I don't have a high school diploma. Maybe they want help with secondary education. They go into the CareSource Job Connect program. And so they are, again, and very likely that those members that would like employment also have SPOH barriers, right? We're working with Medicaid population. So really our life coach works to stabilize them if they're in crisis or if they have significant SPOH barriers. And then they start working toward, what is it that you want to do? What kind of employment do you like? If we give them all kinds of different scenarios, and we really try to get the member to come up with their own solution, right, to their own goals that they want to meet. We're not telling them, this is what you need to do. This is the paperwork you need to fill out. This is a job you need to try to get. This is really member driven. And then another thing that makes us really unique for other workforce development programs is that we stay with the member, if they want, after employment. We find that this is kind of where they really sort of need a life coach more. They just don't know it yet. And so for that member that's been unemployed for a while and now suddenly has a full-time job, that can be really hard to navigate, all the things that come along with full-time employment. And so our coach is there still with them. How are things going? How are you doing? And really even up to, hey, I'm doing great, but I think I might be up for a promotion. I've never experienced that before. Can you help me with what, to prepare for that? So really just that is very different than traditional workforce development programs that really can't wait for that case closure, right? That 90-day retention. Okay, you've got it. You've got a job. Move on. We're there really to move that member past that early phase of employment and get them to where they actually want to be. So those are a couple different things that we are really proud of and that differentiate us from other workforce development programs.
Okay, I have to. So that was gold. So it's a voluntary program. That's one. So members could disengage. The key here is life coaches. These are case managers, social workers, member facing.
Yeah. Yeah,
right?
so some of them are social workers, some of them are not, but some of them have been certified through International Coaching Federation. CareSource paid for many of our coaches to go through that program. I actually went through that program. And so we really take the coach approach so it's a little bit, now there are some members that we find that just need sort of case management, traditional case management, totally fine. But we really are trying to get that member to come up with their own solutions to their own goals to meet their own goals.
Awesome. So just folks, I apologize to folks listening on the podcast, but if you're watching or listening live via Zoom, you're probably noticing that we're sort of posting snippets of the notes we're taking live in chat. It's a new feature. So just for coming, and we can't really, so for those of you, this is an incentive to come watch these things live for us. So Terrie, we're going to post, I got some good notes here from this. One of the other things that you said, and I want to make sure we got it right, you're focusing on that barrier busting, like the housing, the childcare, the transportation. Are those the barriers? Let's bust through them. And you're focusing on stabilization first, then job readiness and employment.
Absolutely.
And the other key point that I think that everyone, as you're thinking about financing this and building it or enhancing yours, is they don't wait. What I heard you just say, you don't wait for the 90-day closure, right? Just to check it off the box. You actually stay with the member if they want and ensure that the member has a long-term chance, a chance of long-term success.
That's exactly right.
All right, we'll put that in the notes too. Again, if you're watching live, we're trying to use that chat. Incidentally, folks, we're going to send you a survey in about 10, 15 minutes. I have a small, lean, mean, smart, hardworking production team, and they rely on your surveys to make sure we hit the right topics and enhance our content. This note-taking thing that we're doing, I got 2 producers behind the scenes working their tail off to get it to you. That comes from your feedback. We want to make sure we're doing it well for you and enhancing your experience. We just believe these are different from your traditional webinars. We want to continue not just talking like the talk, but walking it. Molly, let's come back to New England and let's talk about work requirements, which could return as early as 27. And the last redetermination cycle showed how fast policy decisions ripple into operations and member engagement, cost, care, everything, right? So from where you sit at this intersection of strategy and state planning, how are you engaging with your markets, your states, and actuaries so that you aren't getting caught off guard the way maybe lots of us were back during the last cycle?
Yeah. Size fits all approach to how to work with states. I think you have to really understand the state that you're operating in, because the changes that are going to be coming under OB3 are going to look different depending on the state Medicaid program itself. So like I said, we work both in Massachusetts and New Hampshire Medicaid. How OB3 is going to impact each state is going to look different. There's a common saying in the Medicaid space, if you've worked in one Medicaid state, you've worked in one Medicaid state, which I think is going to be really true, especially as we think about work requirements and how states are going to fulfill the requirements under OB3. I think you need to be very aware of the state that you're operating in. So some things that you should be asking yourself in terms of how you want to interact and advocate with the state is understanding, is it an expansion state, right? If your state hasn't expanded Medicaid, you're probably not going to be dealing with some of the same challenges as a state that has expanded Medicaid. Another thing that you should be very aware of is, what is the minimum wage in the Medicaid state that you're operating in? So work requirements say you have to work 80 hours a month at the federal minimum wage, which is, I believe, $7.25 an hour. In Massachusetts, our minimum wage is $15 an hour. So what that means is that members will be able to satisfy work requirements by working 39 hours a month, as opposed to that 80-hour a month requirement. In New Hampshire, that's not going to be the case, because in New Hampshire, the minimum wage is the same as the federal minimum wage. So in New Hampshire, members will have to work 80 hours to meet the work requirements. Other things to think about with your state is, does your state cover non-citizens? Some of the eligibility requirement will have to change under OB3. Also understanding the politics of the state that you're operating in. What does their relationship look like with the current administration? And also understanding the status of the current 1115 waiver that they have for their Medicaid program. When is that up for renewal? what changes might the state have to make to their Medicaid program to ensure that their 1115 waiver is approved by this new administration.
I just
Yeah.
want to, I have a quick follow-up because it's super great to have someone with your experience kind of in an episode like this, because it just creates an important purview that we typically don't have. What would be, as you're probably talking to a lot of folks who oversee Medicaid product, maybe they're in charge of Medicaid engagement, what would be your advice or message to them as far as what you would be if you were in like an executive consulting role to them right now, as far as what they should be thinking about? Like, what's your message to them?
For a health plan or a Medicaid agency?
Medicaid for a health plan.
So I think it depends on what their product line looks like, right? How heavily hedged are you towards Medicaid? How much are you also in the ACA book of business as well? Because we're talking a lot about Medicaid, but there's also going to be a lot of changes to the individual marketplace as well, right? So I think for both, communication with members is going to be really critical, right? So as we think both in terms of the individual market, where there's a lot of uncertainty around premium subsidies, and if those are going to continue, having good communication with members so they understand what protections are going to be in place is going to be really important during this open enrollment cycle that we're going through right now. Unfortunately, there's not a lot of direction from the federal government,
but that's where you could also, right? You could proactively. I think you were talking to my producer, about proactively trying to shape the state's approach.
Oh, for sure.
Right?
Yes. So that's going to be really important for Medicaid, right? Because I think one thing that we should all be aware of is other states that have tried work requirements haven't been able to demonstrate large savings, right? So cuts are coming to Medicaid. And if we're not able to achieve savings through work requirements, they're going to have to be found in other places, right? So I think there is a real opportunity for all of us to come to the table and say, how can we make sure that in the current budgetary environment that we're operating in, we're doing the best thing for our members and for our patients? And what are some of those creative and innovative ideas on how we can think about streamlining the program or think about delivering the same quality of care, but at a lower cost, right? And that's going to require engagement from not just from health plans, but also from the provider community as well. I think there should also be a member engagement component to that as well. So at WellSense, we're doing that directly with the state agencies. As I said, we're part of Boston Medical Center Health System, so we're also talking to our provider folks on understanding from a clinical perspective what are things that we should start proposing and thinking about. In Massachusetts, there's also a health plan association that we've been working with. So I would encourage for those that sit in a health plan role where they're actively thinking about this, does your state have a health plan association where you can talk to other folks that are dealing with the same challenges and you can think about, okay, how do we build a coalition and how do we think about maybe jointly advocating for proposals that we think will, directly benefit our members.
Perfect. You're setting me up beautifully for the next question. So, I would say, like, right, 2027 is coming real fast, right? And if health plans don't start moving, they're going to be in trouble. So, Abner, as I mentioned to you the other day when we were talking, I grew up playing hockey, so I'm required by law to quote the famous Wayne Gretzky quote, where you need to skate where the puck is going, not where it's been. So strategically, Abner, what should Medicaid plans be doing right now to get ahead of new work requirements and the next redetermination cycle? And what are like maybe some of the concrete actions, rather than preaching like why they should be moving? I think like Molly even set the stage. Like we know we need to get moving. It's hard within a Medicaid plan or any health plan. Any organization with the bureaucracy, but like to move fast, but what are the 4 or 5 concrete actions maybe that plans can take to overcome inertia and start skating to where the puck is going?
Sure. So a great question, and I want to just agree with Molly. It's really important for the plans to be working with their state and even with CMS and with each other. That's really important work, and having and sort of planning internally. And I get the sense, I talk to a lot of health plans, that they are doing that. But the other thing that's really, really important, and it's really three things I'll focus on that I would encourage, that we're encouraging our plan partners to do. And it's all about communicating with the member. Everything, all of the other work is important, but the member communication is really important. And don't wait. Our advice is don't wait until the end of 26. In fact, we suggest a different schedule, and I'll be very specific. We're suggesting that plans should stratify their member population, those folks who are in the expansion population who are going to be subject to work requirements and new redetermination requirements. The plans have the information to stratify that member population into people who are at low risk for losing their coverage, people who are at medium risk for losing their coverage, and people who are at high risk for losing their coverage. Our suggestion is that plans do that by the end of the second quarter of 26. And that allows the plan then in the June, July kind of time frame to actually reach out to members. And plans, you don't need to have CMS involved or the state involved to know if your members, their personal situation puts them at risk. Plans have that information. The state doesn't actually, nor the CMS. So plans can risk stratify, and we're suggesting in mid-year 26, reach out to your members, communicate with them. And that communication achieves a couple things. One, you can validate that they really are in that risk category. Ask them, and you may find that they are at risk in ways that you didn't know, but ask them. So in that mid-year time frame, reach out. Two, it'll establish a mode of communication. Don't wait until someone's at risk for losing their coverage to figure out how to communicate with them. Communicate early. And texting is now an option that it wasn't before because of the law. We can get into that later, but people should take a look at that. Plans are going to, I think, be able to text in a way that they haven't been able to without regard to the Telephone Consumer Protection Act, which has been a constraint. And then last but not least, that mid-year communication should send a clear signal to your members that you care, that you're committed to helping them keep their coverage. We're about to enter a period where there's going to be a lot of fear, a lot of confusion, a lot of misunderstanding, and plans have a crucial role to play in helping their members manage that fear. So act now. Don't wait for CMS. Don't wait for the state. Stratify now and engage and start communicating early. Establish the forms of communication that work for that member, specific to that member, because that's the way to make sure that when we ultimately start to roll things out in January of 27, it is done in a way that reduces unnecessary loss of coverage.
Good stuff. Good also segue for me, Abner. I just wanted, you weren't here for my first kind of ground game promo, if you will, but wanted to let everyone know, joined late. Like Ground Game is a partner to Bright Spots in Healthcare now, and helped us get educated around today's episode. And they've not only lived through all of this, but they lived through the COVID redetermination across dozens of states, and helped state implementations where plans just had to operationalize something really fast when it was vague and the stakes were high. They just released a white paper on Medicaid work requirements that gives a very clear picture of what you're facing and kind of outlines in more details the answer that Abner gave as far as a blueprint. So if you're looking to get a blueprint for like where you should be going, where you should be going, ahead of the puck, you're going to get some real great content from this white paper, and I'm happy to send it to you directly if you want it. It ties right back to the Helsinki story and insight that we started with. When you redesign the experience so people feel confident and supported, everything's going to change. And this report gives that blueprint for doing exactly that as work requirements and redetermination pick up speed here. So if you want a copy of that white paper, just click yes in that poll. We'll send it out to you. You don't have to fill out another form or search for it and go through some gate. We'll get it right out to you, and you'll get sort of the outline there. All right, let's now build on this and this idea of moving early and designing for where the puck is going to be. And I promise that's the last time I will bring up the Wayne Gretzky quote. So CareSource is doing that in a very real way, right, with their Job Connect program, especially as they expand into new markets. So Terrie, as you bring Job Connect across the country, what's different about your approach, and what does it really take to launch this program successfully in a new state? Let's give a little away here as folks are thinking about how to make their communities better.
Sure, absolutely. Yeah, it's all based, well, the beginning part of it is based on finances. It's based on membership, expected membership. So our Ohio market is the largest life services team because it has the largest member base, right? So each time we go into a new market, we look at all of that. And we replicated after Ohio, we took it to Indiana, and then Indiana, we took it to Georgia, then Michigan. And so it's all really the program. We'd like to keep the fidelity of the program, the processes, the procedures, everything's aligned, but it looks a little different in every state just because states are nuanced and the population differs. How the expected membership, how many health plans are in each state. The one that is going to be very different is our Nevada implementation, which starts on 1/1/2026, go live. We decided to try something different in Nevada while we still have our internal life coaches and our internal team. The state of Nevada was really interested in, when we wrote the RFP and we won the RFP, is to really take the money and put it into the community-based organizations in the state that can do some things and that are doing some things and sort of lower duplication efforts, that sort of thing. What we chose to do, we started out with 2, but for various reasons, we ended up with 1, which is fine. We gave the money directly to the community-based organization to hire a life coach. That life coach then will deliver the program as if they were a CareSource employee, and they will cover their own service area that their own community-based organization covers. And so we're going to have sort of what we call an external model and an internal model. And we're really going to start looking at that and looking at the differences and does it work and where are the pain points and things like that. And we think that maybe there's an opportunity, if it works well, to really sort of grow the external model and to really give it back to the communities, but then pay that community-based organization for that life coach, for hiring that individual instead of hiring all internal staff. So it's an exciting new pilot. We'll see how it works, but we really listened to the state when the state said we really want as much integration for community-based organizations as possible and not have everything done by the MCO. So we'll see. It's interesting. It's fun. It's a fun new adventure. But really, it matters to everything depends on what your membership looks like in the new states that you go in, how big your team is, how it operates, that kind of thing.
What would be, you said a lot there, but like if you were going to, and I know this is going to be a hard question that we didn't prepare for. What's the one thing like that you would advise your peers to do? The most important thing that's going to give the most leverage, it's going to cascade everything you just said. Like, what's the one thing you have to have nailed down as a health plan to successfully do something like Job Connect?
I think it's fidelity to the model. I think that once you get, and sometimes that's difficult for a health plan because a lot of times a health plan, when they have their markets or their states, they have their own alignment, their own P&L. And sometimes if you have the program in multiple states, it can get a little hairy because then they sort of try to form their own process and procedures. And if you really want to stick to the model, I think that's really important, is to stick to the model, stick to what we know works. And you can innovate and process improve, but this program's been going for a decade in Ohio, and so there's not a lot of it's not new everywhere, right? So stick to what we know works, and really invest. And I think top-down investment, not just money investment, but really the buy-in from the leaders above. If you don't have that buy-in, you're not really going to be successful because it's just going to be another value-added benefit, right? It's going to be another thing you throw in an RFP. That's really not that's sort of a recipe for disaster.
Abner, by the way, folks, if you haven't seen it in the chat, it's also getting sent to you through email. Like I said, my production team wants your feedback to build upon everything we're doing for all of you in the market as far as these shows in first quarter and now second quarter. So Survey Monkey, easy, 2 or 3 minutes to give us your feedback. Thank you. I get shot if I don't remind you to do that, by the way. Abner, talk to me a little bit, like give me an example of a health plan who is truly connected with members who weren't necessarily engaging through more traditional approaches.
Sure. So maybe this is the time to talk about how we're helping our plan partners to solve social needs.
I'm thinking
Is that
about
what you're getting at?
I'm thinking about that Medicaid plan on the West Coast.
Okay, got it. Okay, so really that's more about this. We worked with a large plan in Medicaid plan in California that was. This is during the COVID era, so I'm just taking people back just a little bit. This is during COVID. This is a large Medicaid plan. They had a huge Latino membership, and they were really struggling with getting Latinos to get vaccinated. Once the vaccinations were available, they really were struggling. There was a lot of vaccine hesitancy in the Latino community. And so this plan turned to us and said, can you help us? We are struggling, and the vaccine is available. It's free, but people aren't using it. And so what we did was we said, okay, let's figure out what's behind this. And we found a couple of things and learned some lessons. One was that it's really important to listen. We made mistakes sometimes of coming in prejudging. It's really important to listen without judgment and understand what people's concerns are. We were able to get what I would say behind the vaccine hesitancy. And part of that was looking at the news sources that these members are getting their information from, and then designing messaging that addressed the issues that were being raised in those information sources. It's not what I would normally read. Maybe it's not what you would read or listen to, but this is where people were getting their information from. So one, we decided to engage, to listen, to not judge, but instead to respectfully respond with information to help members to make a good decision. And we think the good decision was to get a vaccine. The other thing that we did was we by listening, we uncovered something. And I think Terrie may have mentioned this earlier. We uncovered that for the Latino community in particular, within a household, if we could get one person to agree to get vaccinated, that was a lever that we could use that person could talk to other people in the household. And we agreed that we would actually make the appointment for them on behalf of the plan. We'd make the appointment for the whole family. In fact, not just the family, anybody who lived in that house. We called it householding. That householding approach was incredibly effective. We would get sometimes 7, 8, 9 people coming in at one time to get the vaccine because we had built trust and we understood the way that household operated. And so the end result was this is based on vaccine data from the state that the plan shared with us. Latino members that we engaged with were 18.4 times more likely to get a vaccine than Latino members who we didn't engage with. And that was a huge lift for the plan. So the point here is listen without judgment, and of course get the basics right, like language and mode of communication. Don't send mail. You got to text people, and then finally, this is an example of what I think we're about to enter a phase in late 26 and 27 where the same kind of distrust of the system, particularly in Medicaid, is going to happen because of work requirements. And what we've shown, the important part of, to me, the result of this COVID work is that even when there is high mistrust, you can build trust. You can navigate through that. And I think that's a lesson for us as we approach 27, because there's going to be a lot of fear, a lot of mistrust, a lot of lack of information. But if we're willing to personalize, to listen without judgment, I think we can help people navigate through what is about to happen in 27.
Got it. That's great. Great guidance for us. Quick follow-up, and I would love to could you give me an example, or all of us an example, of cases where like the traditional clinical interventions weren't enough, to share, maybe a situation where you had to address the other things going on in someone's life where transformation wouldn't be possible if you didn't combine that with clinical, and how that was so incumbent that you built that trust and then were able to move the needle. Maybe get like very individualized here, just so we could kind of picture how this all could work, moving all these parts.
Sure. Yeah, this gets to a big part of the work that GroundGame.Health does with our health plan partners. We're working with a national plan across all their lines of business to help them solve their members' social needs. This plan figured out that they couldn't achieve their clinical goals with the member unless they resolved or helped solve the social needs. I'm talking housing insecurity, food insecurity, transportation, lack of income, domestic violence, all sorts of issues that got in the way of the clinical goals that the plan had for that member. And so what we have done at GroundGame.Health in partnership with the plan is that we've established basically a relationship. We call it upstream with the plan. We have a contract with them, and downstream with community-based groups. We found that community-based groups, and that's why I love what Terrie just said about what's happening in Nevada with them. We believe that community-based groups are a great partner for health plans to help them solve their members' social needs. It means the health plan doesn't have to become a social service organization, which health plans aren't so good at. It means that they can partner with people who are good at that. It's just that it's hard for a local food bank to contract with a health plan. They'll never do it. They don't have the high trust and the insurance and all those sort of requirements that are required to contract with a health plan. So what GroundGame.Health has done with our health plan partners, we sit in the middle. We contract with the health plan on the one hand, and with the community-based group on the other hand. Referrals are identified through our technology platform, and we're able to connect that member to a local resource that can help solve their social need and get it verified through our platform. And actually, the health plan in this case is making a payment. They're willing to pay to get their members' social needs solved because they know that's part of the strategy for them to achieve their overall goals. So we're doing that at scale across lines of business. So it's not just Medicaid, it's across lines of business. And the key thing here is that it allows the community-based groups to do what they do best. It allows the health plans to do what they do best. We're simply the sort of pipes in between that allows for that to happen in a sort of seamless, smooth way.
Good stuff. 2 minutes left. Sorry, guys, we've been running way off schedule, but it's been great content. Terrie, I'm going to let you close up with, you've talked a lot about your program, but let's talk about the ROI and what you've learned about the impact of workforce development programs, both from navigating redetermination and the workforce requirements, and then also for helping members maybe move beyond reliance on Medicaid. Like, what do you see and how you're looking at impact and ROI?
Right. Yeah, the reliance on Medicaid is an interesting topic because we often get asked, why are you doing a program that actually is moving people off of your plan? And the answer to that has always been because it's the right thing to do. But we do see an ROI. So there's a couple different things. A few years ago, we developed a dashboard that took the claims data 6 months before that member had a life coach intervention and 6 months post with the claims data. They had to have a 12-month consecutive eligibility criteria for CareSource so that we'd have those claims data. What we see on a regular basis, and from 2021 to 2025, we sort of aggregated it. We saw a 16% reduction in ED utilization. We saw a 12% reduction in inpatient care, and we saw a reduction in total cost of care. And so that's the first kind of an ROI that you can sort of point to. Then we hired Health Management Associates, HMA, to do a third-party evidence-based sort of ROI study. They posted that on LinkedIn. What they found was they did a benefit cost ratio and an ROI, and utilizing indirect benefits and direct benefits and the multiplier effect, right? So if someone has employed, the taxes that the state gets, the money back into the state economy, that kind of thing. They showed Indiana and Ohio hovered around a 13-to-1 ROI. Georgia had about a 6-to-1 ROI. And it's about the same for the benefit cost ratio and the straight ROI. So not only do we see a claims reduction in total cost of care inside the health plan, we can go to the state and say, look, there is a benefit for the state to fund this. Because remember, right now, CareSource funds all life services staff All the money comes out of CareSource. Medicaid does not pay for our staff salaries and the work that we do. We are trying to move that needle. We're trying to get for work requirements. We have a consultant working really hard to try to get it in the MLR as self-sufficiency. That would be a game changer for MCOs. So that admin cost, so it doesn't come out of the admin cost, right? Yeah. And so that's, those are just some things that we're showing great outcomes with our program.
Great stuff. I'm going to ask all of you to stick around for a second as I close up here. Sorry, we're a minute late, folks. This was great. If you only knew some of the stuff going behind the scenes today, but we pulled it off. I hope you got some value out of today. I think that when you're thinking about those members who are the members who need you most are probably the ones who are scared to come to that bus station, the ones that are confused and don't feel confident in the system. So get that cover at the bus station, get some lights there, get some color-coded maps and make it really simple, make it easy to get in and off the bus, and you have a better chance of them coming. I hope you use the ideas, the bright spots discussed by all of our guests today during this episode to help you improve what you are doing at your health plan, at your company, wherever you are, and making healthcare better for all of us. I want to thank you all for spending the hour with us. We truly appreciate it. A special thanks to our production team, including Vakanda Luangapai, our producer who brought us all together today. We put this show together each week for all of you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone. Thanks again.